Faith Leader Advocacy for Malaria Elimination in partnership with the Ministry of Health and End Malaria Council brings to you Flame Radio program.
It ends with me.
It ends with
Malaria
me.
will end with
Malaria
you.
ends with me.
It ends with you.
It ends with me.
Neighbor, neighbor, neighbor. Ukazikona muneti neighbor. Malaria sisanka you a neighbor. So protect your family, my neighbor. Oh, wow, get tested. Ulinaka fever, get tested. Ulinaka headache, get tested. Together we can end malaria. Every night, sleep under a treated mosquito net. Ngati bakupeza na malaria. Mangwala bakupaza uzisiriza. Did you know, spraying your walls is the best. Osawala, mangwala ya malaria yali safe.
Neighbor, neighbor, neighbor. Ukazikona muneti neighbor. Malaria sisanka iwe neighbor. So protect your family, my neighbor. Neighbor, neighbor, neighbor. Ukazikona muneti neighbor. Malaria sisanka iwe neighbor. So protect your family, my neighbor. Mukambera koka mpepo, mukambera koka mutu. Osatayanta wiwantu pitani kuchipatala. Azima ya pakati, nabana ba under 5. Nazi bambo zonse, konani mu mosquito neti. Musayo pe ma spray, musayo pe ma neti. Izindi enjila, so chingiliza uzuzu.
Neighbor, neighbor, neighbor. Ukazikona muneti neighbor. Malaria sisanka iwe neighbor. So protect your family, my neighbor. It ends with me.
It ends with
Malaria
me.
will end with you.
Malaria ends with me.
It ends with you.
It ends with me.
We're back here again this week with another presentation of the Faith Leader Advocacy for Malaria Elimination. Now, the Faith Leader Advocacy for Malaria Elimination has a number of partners beyond the clergy. On the program today, I'm very privileged to host Programs Manager for Partner Malaria Zambia, based in the Muchinga province. He will tell us what his name is and what his organization is about.
My name is Eric Liswaniso. I am Programs Manager with Malaria Partner Zambia. So Malaria Partner Zambia is a Rotary-owned NGO. Our offices are based on the Copper Belt, but we have projects in 3 provinces. We have projects on the Copper Belt, Muchinga, and Central Province, where we are working with another partner, World Vision. Yes.
So speak to us about your involvement in the fight against malaria.
Okay, so Rotary has been doing malaria for quite some time now. The project that I'm currently working on is called the Partners for a Malaria-Free Zambia project. As the name suggests, it's a partnership. So the project is jointly funded by Rotary, the Bill and Melinda Gates Foundation, and World Vision International. So Rotary is leading this intervention, and it is being implemented on the ground by World Vision Zambia and Malaria Partners Zambia, which, as I indicated earlier, is a Rotary-owned NGO. I am in charge of the Muchinga region. We are working in 4 districts in Muchinga province. That is Lavshimanda, Kanchivia, Shuangandu, and Impika. The goal of the project overall is to train and equip more than 2,500 community health workers. 2,500 community health workers, each catering for a population of at least 500 in the catchments where they are coming from. So if you do the math, 2,500 times 500, we are providing primary health care for more than 1.2 million Zambians at the end of the day. So what we do on the project basically is we go to the communities and through the community structures identify members of the community that are willing and able to help their communities as healthcare givers. They have to be able to read and write. That's the only precondition, and they have to be available to serve. Then we bring them here and we train them. So they are trained for 6 days in what is known as integrated community case management, which equips them with the skills that they need to be able to address community ailments like diarrhea, pneumonia, and most important of all, malaria. So they are trained how to test for malaria, determine that this is malaria, and administer treatment for malaria. To enable them work smoothly, we provide them with a comprehensive starter pack that includes everything that you need for a mini clinic in a home, basically, and so including a bicycle and a smartphone. The smartphone is for reporting, which I can explain later, and the bicycle is in case of a referral. They have been fully trained to know how to handle complicated cases, so they know that if this is a complicated case and it's beyond my scope, they know to refer it to the nearest health center, which, as you understand, with the terrain here, sometimes it's 5, sometimes it's 10, even 30 kilometers away from the nearest health center. Hence, the bicycle helps with ferrying such patients to the nearest facility where they can receive advanced health care. Yes.
Could you tell us about the impact that your program has had on the communities that you're serving?
So far we have, because the goal was to saturate the districts where we are serving, and so far we have saturated Lavshimanda, Kanchiria, and Impika, and by the end of June we would have saturated Shuangando as well, because Shuangando is currently in training. The impact has already been felt, and we have a system where we monitor the data. I mentioned that we give them a smartphone, so that smartphone is for every case that visits their home to receive care. They are recorded in a register, and then that data is uploaded into what is known as the DHIS2 system. So it's an online system which records all the interventions that are happening at community level are captured by DHIS2, and from the comfort of wherever I am, I'm able to track and see what is happening. I can tell how many community members have been attended to by a community health worker, how many of them had malaria, how many of them were successfully treated at community level. And so through that, we're able to monitor that the levels of malaria are dropping or are they going up, and it's able to inform policy in terms of, okay, what other interventions can we implement? And so far, the reporting rates from the districts that we've trained have been good, and it's been able to guide us in terms of what other interventions that we can do in those districts. We provide them with talk time every month. That makes it easy also for them to do their reporting. Yeah, so I would say it's too early stages in the project. We only started doing this last year, but definitely the impact is being felt, and I think our funders are very happy with the progress that we have made so far, and our only hope is that further investment can come and we can reach even more Zambians with primary health care. Yeah, so we do not just end with the community health worker. There are other interventions that we do. We are also mobilizing the community and doing some sensitization activities. So we do sensitization through media and radio, like we are doing right now. We do sensitizations through community drama performances, where we go to the community, mobilize the crowd, and speak to them about malaria prevention and control. We are also mobilizing faith, civic, and traditional leaders. So last year we trained about 80 a combination of faith, civic, and traditional leaders from the 4 districts in Muchinga province, and we trained, that is 20 times 6, that's 120 faith-based leaders in Central Province as well. So in total, you're talking about 200 community influencers trained and equipped with malaria messaging so that they can become the agents of change in the communities where they are coming from. So it's an integrated approach. We also do other data review activities where, I mentioned that we give them a phone and they are able to report using the phone, but, there are data quality issues that arise sometimes, and so we still go back to the community every so often to interact with the community health workers and just assess the quality of the work that they are doing, and where additional training is required, where technical support supervision is required. We provide that just so that the data that we are receiving is clean and it's accurate, and it accurately portrays the picture that is on the ground. Yes.
You mentioned some of the partnerships you have, but could you explain the relationship that you have, for instance, with government through the Ministry of Health, who primarily are, the owners of the mandate to provide the healthcare services?
Thank you very much. And as you've rightly said, the mandate to provide healthcare services in Zambia is solely the responsibility of the Ministry of Health, and as partners, we merely come in to support. So the ICCM that I spoke about, the Integrated Community Case Management, this is a purely government initiative, and it is enshrined in the strategic plan. I think when we started the project, there was a strategic plan that was running between 2017 and 2021, and starting this year, I think there's a new strategic plan that has been launched, and so whatever we do feeds into that strategic plan and the overall legacy goals of the Ministry of Health. So the trainers, if you get to the classroom and find the trainers that are doing this training are all from the government, and we merely come in with the resources, and we are supporting that intervention that way. We do not work alone, like I mentioned. We are working with World Vision. We work very closely with PATH, MASEPA, who are, I think, veterans in the malaria space. We here in Muchinga, we are also working very closely with PAMO Plus. As I am speaking to you, some of my colleagues are undertaking mentorship, technical support, supervision with PAMO Plus in the community. So it's an integrated approach. We are not working in silos. We are contributing to what I would say is actually a very good malaria strategic plan. I think Zambia is a model when it comes to what we are doing in terms of malaria prevention and control. And it even makes the goal of eliminating malaria in Zambia more realistic than I would say in many other parts of the world. We've become a model for most of our neighbors. They come here to learn about how we are addressing malaria.
Given your experience working in this area, what would you say about the seriousness of the malaria disease burden?
Yeah, thank you very much. And it varies, but malaria is it's stratified in certain levels. Like there's what we call you have level 0, level 1, 2, 3, and 4. And the lower the number means the lower the malaria burden. I think where you're coming from, Lusaka, is one of the territories in this country that are almost malaria-free, Lusaka and Southern Province. And that the model that worked in Lusaka and Southern Province is actually what we are implementing in other parts of the country, like what we are doing here. And so what basically it means is when you are in level 1, level 2, you are quite lower. You have very low malaria incidence. Most of the districts that we are working in are either level 3 or level 4, which means the burden is really very high. I was at a facility just 2 days ago where the incidence rate was more than 100%. Of course, we don't count it in percentages, but you would open a register and a whole page, for a community health workers register would be malaria tested positive, and the whole page is positive, meaning everybody that went to see the community health worker was actually found with malaria, and so the burden is quite high, but it just maybe emphasizes the need for what we are doing. Yeah, and I know there are many parts of the country that do not yet have this kind of intervention. But the beauty is now when we have trained the community health workers, we have foot soldiers that are going to be doing the work at community level, doing the sensitization, doing the testing, doing the treating, and with that we can drive malaria down. Yeah.
You mentioned that you are working in highly burdened areas where malaria is concerned. What do you suppose are the drivers to this situation?
There are a number of factors, really. Sometimes it's lack of awareness, and that's why social behavioral change communication is very important. And some of the other drivers is maybe lack of interventions before maybe we stepped in. Like, malaria elimination has to be an integrated approach. You need to do IRIS, which is indoor residue spraying. You need to do ITN distribution, which is insecticide-treated mosquito nets. People have to sleep under insecticide-treated mosquito nets. You have to promote a culture of sleeping in. It's one thing to just distribute them, but it's another thing to ensure that people are sleeping under mosquito nets. The other thing is the distance to the facility. If the hospital is 10 kilometers away and somebody has a fever, they are most likely going to just brush it off and say, mutwefia, and before you know it, it becomes severe malaria, and people end up dying. I know when you're coming from town, hospitals are all around us, and sometimes you don't realize that people are still dying of malaria, but you'll be surprised to learn that malaria is still the number one public health concern in Zambia. No disease kills more people than malaria. Not only in Zambia, it's everywhere. Malaria has killed more people than COVID. Malaria kills more people than HIV and AIDS, and so it's some of those interventions. So when we take healthcare closer to the communities, it now makes it easier for people to access that healthcare. Instead of walking 10 kilometers to the nearest health center, now you can walk to your neighbor's house and say, I think I'm not feeling well, what could this be? And then that is addressed. So sometimes the high number of cases that are detected is because now we are detecting them. Remember, these are cases that would have gone under the radar had the community health workers not been there. But now that we have people in the community that are, testing for malaria, it's easier to detect, and now we are able to capture that number and say, 200 people had malaria in such and such an area. We wouldn't know that before the community health workers went there. So it's also natural that initially the numbers might spike and it might appear like you have too much malaria now. It's because it's now being detected, and that's a good thing. And then it also now makes it easy for you to now target and say, how can we bring it down over there? Yes.
Are there any challenges you've encountered since you began with your program?
Last year was quite challenging. We achieved all our targets, but it wasn't without challenges. And I think the most obvious one was COVID. And I know we are still grappling with COVID, but you see, step one of the whole project is train the community health workers. To train the community health workers means bringing them to a place like this in a conference room and training them. But public gatherings, as you may be aware, were restricted because of COVID. And so for some time, we could not train community health workers. But then again, we sat down and said, look, we are suspending an intervention that saves life because of another disease. COVID is killing people quite all right, but malaria is also still ravaging communities. And so the compromise was, okay, we will continue to train, but instead of having 40 students in a classroom, we will have 30 so that you can facilitate for social distancing. Obviously, that comes with cost implications. It means you have more sessions than you initially planned for. Having more sessions than you initially planned for means you spend more money. The cost of training went up, so our budget got constrained. Then there are also other things that you initially do not budget for when you are planning for such a program, like face masks. Now we have to distribute face masks. We have to distribute hand sanitizer. The project overall will train 2,500 community health workers. So project that across 2,500 community health workers, including staff, because we are also training the facility staff from the facilities they're coming from, including the trainers. So everybody in the training session has to be protected. So you provide face masks, you provide hand sanitizer. So the cost of training went up. But we also, I mentioned that we equip them with a starter pack, and one of the things that they get is that bicycle. Those bicycles, some of them are assembled out of the country, and supply chain issues were also constrained due to COVID. So we're having instances where a class is graduating, but the bicycles are not yet in country. And so logistically, it becomes a challenge to deliver the bicycles to each community health worker after the fact. But in hindsight, we still managed to deliver all the bicycles for all the community health workers that we trained last year. We trained 1,300 last year. This year we are training the balance to get to, we are training about 825 so that we saturate the 2,500. Yeah. So this year has been better. Our class size is still constrained due to COVID. So we can only train a maximum of 30 community health workers, so we are still spending more. But it is a necessary adjustment. At the end of the day, we need to make sure that everybody is safe during training, even as we seek to achieve our goal.
Lastly, Zambia has a very ambitious goal. The legacy goal is to end malaria by 2026. Through your eyes, is this tenable?
to do this work, you have to believe that what you are doing is tenable. And for me, this is not just a job, this is a calling. And when you sit in class for 6 days, like those community health workers are sitting in class, and you learn about the interventions and how malaria can be eliminated, and you read about other countries like China that have achieved malaria elimination, then you know that this truly is tenable. But I know there are a lot of public misconceptions, because we grew up with malaria, and so we think it's natural, it's a disease, it's just something we have to accept and live with. But as a Rotarian too, I'll tell you that not so long ago, polio was endemic, including in Zambia, but polio has been eradicated completely in Zambia. And there was that one case in Malawi, which was actually an imported case, which triggered this response of the recent polio vaccinations that we saw recently. But that what we achieved with polio as Rotary just gives you an idea of what is achievable when you believe in what you are doing. And so malaria is very eliminatable without even going very far. Some of you are coming from Lusaka. When you go to the clinic, you are not even tested for malaria. Malaria is almost non-existent in Lusaka. You go to Southern Province, you go to Macha, there's no malaria in Southern Province. If they could achieve it in Southern Province, we can achieve it everywhere else in Zambia. So we just need to do enough sensitization, get people to understand what they need to do to prevent malaria. And with all these interventions that we are doing, I believe that malaria will be a thing of the past. And our slogan in the malaria world is "Malaria ends with me." So it starts with what I'm doing and getting as many people involved as possible.
Well, thank you very much for speaking with us.
Thank you.
That was a Flame Radio program, a program designed to highlight achievements and challenges associated with ending malaria in Zambia. Join your presenter next week at the same time. Remember, malaria ends with me.
It ends with me.
It ends with
Malaria
me.
will end with
Malaria
you.
ends with me.
It ends with you.
It ends with me.
Neighbor, 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 ukazikona muneti neighbor. Malaria sisanka you a neighbor, so protect your family, my neighbor. Oh, get tested. Ulinaka fever, get tested. Ulinaka headache, get tested. Together we can end malaria. Every night, sleep under a treated mosquito net. Ngati bakupeza na malaria, mangwala bakupaza uzisiriza. Did you know, spraying your walls is the best. Osawala, mangwala ya malaria yali safe.
Neighbor, 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 ukazikona muneti neighbor. Malaria sisanka iwe neighbor, so protect your family, my neighbor. Neighbor, 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 ukazikona muneti neighbor. Malaria sisanka iwe neighbor, so protect your family, my neighbor. Mukambera koka mpepo, mukambera koka mutu, osatayanta wiwantu pitani kuchipatala. Azima ya pakati, nabana ba under 5, nazibambo zonse konani mu mosquito neti. Musayope ma spray, musayope ma neti, izindi enjila sochingiliza uzuzu. Neba, 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 ukazikona muneti neba. Malaria sisanka iwe neba, so protect your